today's episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom. We'd like to thank our episode sponsor, Bristol Myers Squibb, for their support of this Myeloma Crowd radio show program. Now, smoldering myeloma is a precursor condition that can become active myeloma. The term smoldering myeloma is actually one of debate right now, and we hope Dr. Manasanch will address that topic in today's show. Today we'll be talking about smoldering myeloma, how it's defined, when patients should be treated, and how they should be treated. Just before we get started, I'd like to make just a couple announcements. We are currently working on a genetics study inside of the HealthTree Cure Hub that I want to make sure that you're invited to join. Our goal in doing this study is to identify different treatment paths that might be potentially best for different types of genetic features in myeloma patients. And that study can be found on HealthTree.org, and if you sign in and have an account, you can join that study. We're learning important things already about that. I know Dr. Manasanch will be talking about a few genetic features in this show. And I also wanted to highlight the fact that we have a Smoldering Myeloma Facebook group that you can join. If you just search on Facebook for Smoldering Myeloma, you can join that group. And we also have quite an extensive Smoldering Myeloma class in HealthTree University. So if you go to healthtree.org and log in, you'll see it in your sidebar, but you'll also be able to find it outside of HealthTree, and it's available to everybody at university.healthtree.org. So let me introduce Dr. Manasanch. And Dr. Manasanch, welcome to the program.
Thank you, Jenny.
Let me introduce you before we get started. Dr. Manasanch is Associate Professor in the Department of Lymphoma and Myeloma at the University of Texas MD Anderson Cancer Center in Houston. She's a member of the Faculty Senate, Institutional Review Board, and Continuing Medical Education Committee at MD Anderson. She's earned the High Impact Clinical Research Support Program Award at MD Anderson and the Clinical Innovator Award, also at MD Anderson, and the Brian D. Novus Research Award from the International Myeloma Foundation. She belongs to the Society for Immunotherapy of Cancer, the International Myeloma Working Group, European Hematology Association, and is a member of ASCO and ASH. Her research in myeloma focuses on the introduction of new therapies for newly diagnosed and relapsed refractory patients, precursor conditions like smoldering myeloma, and immunotherapy in myeloma. So we're so excited to have you on the program today. Let's get started with the definition of smoldering myeloma. So everybody used to think about smoldering myeloma like as a stage in this progression. You go from this monoclonal gammopathy of undetermined significance, or MGUS, to smoldering myeloma, and then you progress to active myeloma. Is it like that, or is it its own condition?
Well, first of all, thank you so much for inviting me. I'm very happy to be here today talking about something that is very important in my work life, which is multiple myeloma. Mm-hmm. And so this is a very interesting question that what you're asking, whether if it's, you're asking if it's a stage in the progression or if it's its own condition. And it's really a philosophical question, and there's no right or wrong answer here. But if you ask me what I think it's probably both, right? It definitely is a stage in the progression of a disease that starts, as MGUS. So we have patients that have MGUS that after 10 years, 15 years progress to multiple myeloma, meaning at that time, either they have so many of the cells in the body that they're not allowing, some organs to do their function, such as the bone marrow. So when you have a lot of, myeloma cells in the bone marrow, you don't make red cells, platelets, and so on. So that's one of the things that happen. Now, the other thing is when you have someone that you see in the clinic and they have smoldering myeloma, meaning they have more tumor burden than MGUS. That's, one of the hallmarks of smoldering myeloma is that you have more tumor burden than MGUS, but you don't yet have a lot of tumor burden like we would see in newly diagnosed myeloma, or you don't have, any problems from that, and you feel, otherwise you feel fine. And that's kind of its own condition because the patient situation is very different from somebody who is very sick with a disease for somebody who is not sick at all, or they don't feel sick at all. So even though there's some risk that they may become sick in the future from it. So there's a very different, clinically, these are very different patients. And they are treated very differently in the clinic. And so it is its own condition. However, if we look at smoldering myeloma, most of smoldering myeloma patients have genetic abnormalities that we already see in multiple myeloma. And so it is similar. It is very similar. And the one that is genetically less complex and a little bit more different is MGUS. In MGUS, usually most of the cells, of the plasma cells in the bone marrow are normal. That usually does not happen in smoldering myeloma. By that time, we already see that most of the cells in the bone marrow are abnormal, and, most of the patients that have smoldering myeloma eventually do progress, whereas there's a lot of patients with MGUS that never progress. So there's MGUS is a little bit, less clinically important in the sense that there is much less chance than, for example, a smoldering myeloma to progress to myeloma. And there are some smoldering patients, however, that have features that are very similar to MGUS. So this is all a spectrum, and we all have to remind ourselves that these are arbitrary definitions that can change. So all what we have here, we have patients that have a monoclonal gammopathy. It means that they have plasma cells, immune cells that are producing these antibodies that are not functional antibodies. They don't target an infectious agent or anything. And these patients can be in a spectrum of this monoclonal gammopathy. And that's what we've named those so that it's easy for us to see, to give a diagnosis. But it's really a spectrum. So this question is, it's both. It's a stage, and it's also its own condition, because clinically it's very different from newly diagnosed myeloma, or it's also very different from MGUS. So that's, and of course, you can define as smoldering myeloma. Could be redefined. It could be, sometime in the future we could decide that we don't want to do this anymore, but we don't like MGUS, smoldering and multiple myeloma, that now we should do something different. And so this is an eternal question in the field, and I don't think that there's enough support right now to change it. However, it's something, it may happen in the field in the future.
Yeah, it's so interesting, because I've heard and you may have answered this already, because I've heard some doctors say they kind of want to redefine it, and maybe it's either MGUS or actual myeloma. So you're saying it's sort of this spectrum, but
Well, so this is if we had like MGUS, which would, really wouldn't be, you would also have to redefine MGUS. But if you want to have just MGUS, and then you would have multiple myeloma. So that is also interesting. The problem with that is that, then you would have multiple myeloma patients that would have no symptoms at all. And, some of those patients could have very, low chance. Maybe they could progress, in 5 to 10 years. And then you could have patients who are in the hospital who, are on dialysis, from the myeloma. So these are two very different patients clinically. So I think that, if we have studies showing that, certain patients with a smoldering myeloma will certainly 100% progress. And we know that with a lot of certainty. There's studies with clinical data and with the genomic data and so on. But if you get to the point where somebody will progress, then if you know when, then you can discuss, the risk and benefit of treatment early. But the problem is that a lot of these things depend on the patient. How old is the patient? If you have a 75-year-old person who has a smoldering myeloma that is not very high, doesn't look very high risk, maybe you don't want to treat it, So it is not the same. So clinically, this, there's a reason why it's MGUS, smoldering, and myeloma. It's because clinically it makes sense, because the risk of progression is the risk that you see that when are you going to have to intervene? You very rarely have to intervene in MGUS unless it's related, because sometimes MGUS can cause kidney problems and other things, or you can have amyloidosis. But usually you don't have to intervene in MGUS. And smoldering myeloma, you see people progress much quicker, so you may have to intervene earlier. And then in myeloma, when you have newly diagnosed myeloma, you have to intervene right away. You cannot just wait, 6 months or something like that. So clinically, these stages make a lot of sense. However, whether you have something like MGUS, which would probably not be called MGUS, and then you would just have myeloma, that we would have to know very clearly, okay, these patients that have, this monoclonal gammopathy that is benign, we could call it, you could have a benign monoclonal gammopathy, and then you would have myeloma. And so the patients that have the benign, and I'm just making this up now, but the benign monoclonal gammopathy, then those patients, you could just tell them, you're never going to progress. We don't even need to see you in the clinic for this, potentially, okay? Whereas the myeloma patients, you would say, okay, we're just going to treat you no matter what, because we know that this is going to progress. But this is probably too simplistic, because each patient is different. You have to discuss with them. You have to see the situation and so on. So that's my opinion with all these. I don't know that we will be able to come to a point where you can just say, a benign monoclonal gammopathy and myeloma, because it is very difficult to predict precisely for every patient who will and who won't progress. And so if you're telling someone it's a benign monoclonal gammopathy, nothing is going to happen, then you have to have a lot of certainty for that. And we don't have, that I know of, I don't think we have studies right now that can tell us 100% what is going to happen in the future. All we can do is with some certainty. It looks like this is what's going to happen, and it looks like this is what's not going to happen, but we cannot know 100%. And so that's why, it would be very interesting if we could do that, but I don't know that we are there yet.
Yeah, I mean, we'll talk about the progress that's being made, right? So overall, can you share the rate of progression? Like if someone's diagnosed with smoldering myeloma, what's the likelihood that they will progress, just in terms of like percentages, like what percent of patients end up progressing? And then it slows down over time, right?
Yeah, so something that has been published a long time ago at Mayo Clinic, they said, 1% per year for MGUS and about 10% per year for smoldering myeloma. And then if you don't progress in 5 or 6 years, it can be even less, maybe 5%. And when we do our studies and we look at our patients, we see that this, it keeps repeating the same thing. So one thing is that we can say is, it doesn't seem like people are progressing more now than they were before. So if you, 50 years ago or 40 years ago, you had a patient with MGUS, and you have a patient with MGUS now, they progress at the same rate. So that's interesting, because a lot of this data comes from older studies. But it's every time we look at our data, we look and see, what are people doing? They progress at about the same rate that was published before. So this is still the same. But what I can tell you is that, people that have smoldering myeloma, which is, when you start getting to the point that you have, 20% plasma cells, 30% plasma cells in your bone marrow of all your cells, and these are abnormal, right? These plasma cells usually are abnormal. They have some genetic abnormalities, or they express markers in the surface of the cell that are not normal, and we know very well which ones those are. Then, if you live long enough, you will have myeloma. I mean, most patients that have a smoldering myeloma at some point progress. There's a fraction of those that don't. But if you look, over a period of 10 to 15 years, patients that have a smoldering myeloma almost always end up needing treatment for newly diagnosed myeloma. And so that's why I'm saying that it's very different to have someone who has MGUS to someone who has a smoldering myeloma. These are different. Clinically, these are differentiated, and the risk of progression is just different. And of course, you can have a smoldering patient with, 10% plasma cells, in one biopsy, and then you rebiopsy this patient 3 years later, and it says 5%. Obviously, this patient is still very early on, and it's very different from a patient that that they have 10% now, and you do a biopsy in a couple of years, and now they're 20% or 30%. So, things are not static, okay? Things can change with time. And so that's why follow-up is important, right? So that's why it's difficult to say, because of your characteristics, you may never progress. And all along has published a study saying that, if you have certain genomic signatures in terms of mutations, that, if you have the signatures, then you don't progress until you're MGUS. And if you don't, then you progress. But it's one study, so things have to be validated and so on. So, it seems like we may be getting to the point where we may be able to say, yes, you will know you won't progress, but individually it's very difficult to predict. And all we can say is that usually, having more a paraprotein that is larger in the blood, so bigger paraprotein, having more abnormal plasma cells in the bone marrow, having higher light chains, abnormal light chains. Those things are things that tell us, okay, this is something that could progress in the future. Whereas if you have very few of those abnormalities, then your risk is much less. And those are things that you don't need a lot of fancy tests to look at those things. Those are things that just doing blood work and urine studies you can tell. And so when we want to go beyond that and look at genetic testing, then we have a lot of different tests that we can do. Most of them are research tests, though.
Yeah, like the next generation sequencing or something like that to see if you might have a high-risk feature, that because you're breaking patients into kind of the standard risk smoldering myeloma stage and also high-risk smoldering myeloma. Do you want to just explain the difference between those two?
Yeah, so physicians have tried, and researchers, for a very long time to stratify patients with smoldering myeloma, because I mentioned that if you follow patients with smoldering myeloma, most of them, do seem to end up progressing to myeloma, but there are some that don't. And so as physicians, what we want to know is who is going to progress. We want to know who is going to have problems from this disease, because those are the ones we want to treat. The ones that are never going to have a problem from this one, we don't have to do anything, that's wonderful. You just, you have a little bit different immune system from other people, and that's it. So that's very important for us to know. And so most of the time when people have tried to stratify smoldering myeloma, they have used three tools, I would say. One is the clinical data. So it's like the light chains, the paraprotein, how much myeloma you have in the bone marrow, and so on. And then people have also used genetic features. So Dr. Barlowi, who is retired now, but he used to work at the University of Arkansas, where there's a myeloma center. He was there for many years. He developed a test called the gene expression profiling, GEP70, and this test was very useful at predicting, or is very useful at predicting what patients progress. And this is based on your genetic expression of your myeloma cells. So you have a bone marrow biopsy and you have your myeloma cells taken out of the bone marrow. Those myeloma cells are separated from the rest of the cells in the bone marrow, and then only those cells are analyzed in a machine that can look at RNA in the sample. And then depending on what your RNA expression is in that sample, then that determines your risk. And so that test, tells us, is a good test at telling us who will progress and who won't, which means that, the biology and the genetic abnormalities of patients in their myeloma cells can tell us a lot about who will progress and who won't. Now, that test was using an older technology to do gene expression, and right now people do just RNA sequencing, which is more advanced in terms of the technology, and you can get more information as well instead of this profile, this gene expression profile. And also people are starting to do the single-cell RNA sequencing. And so these are very new technologies. We still are, we don't know a lot. For example, how are we going to be able to use RNA sequencing, not just of all the cells that you can break down. So you can go, you can have a bone marrow, take a sample of cells, you can separate the myeloma cells from the sample, and then you can do bulk RNA sequencing, which means that you're looking at the genetic expression of all the cells together. You take all the cells and you kind of mash them up together, and then you look and see. And that's one technique to do it. But now there's a technique where you can do single cell, which means that you don't, you don't smash the cells together. You can actually look at the sequencing of each different cell. And so that is, again, it's a very new technology. We've just started to use it in the last few years in myeloma. And the ability that gives you is that it can tell you things like, the different subgroups of plasma cells that you have, because it's looking at each different cell. So whereas the bulk sequencing can tell you things like, for example, you will know if most of the cells are expressing a gene a lot that is very important for the cells, then that gene will be expressed a lot. But you're not going to know, how many of those cells have that. You're just going to know overall this gene is very expressed. Whereas if you do the single cell sequencing, you're going to know things like, you have 5,000 cells. You're going to know of those 5,000 cells, 200 have this gene, 300 have this one, 400. So you're going to know the subpopulations.
That'd be very helpful.
So this is very new, and it is still to be determined how we can use that in the clinic. This is just part of research tests right now. And again, it is not determined to know how we're going to use this clinically to know, for example, if someone can progress. The other thing that is very important too is that you can also do this single cell sequencing in the microenvironment. So you can do it in the cells that, not only the cancer cells or the precancer cells, but you can do it in the cells that are around the cancer cells. And those also have changes that are different, potentially if you progress, if you don't progress, and so on. So all these are areas of intensive research. Then again, how can this be used in the future clinically is to be determined.
Yeah, that's fascinating. I think as the technology gets better and these methods get used more and more, you'll have more information. Well, let's talk about the genetic features of smoldering myeloma, because you mentioned that at the beginning, that patients who have smoldering myeloma might already have whatever genetic features they might have if they progressed to active myeloma. So what are the more typical or more common genetic features in smoldering myeloma versus active myeloma? And just for patients, like you can have just so patients know, you can have a gene deletion where you have instead of 2 copies, you can have 1 or none. You can have a gain or an addition of chromosomes, or you can have a translocation where the chromosomes are swapping places.
So it really depends what is the genetic abnormality. And as you mentioned, this was a very nice summary that you can have a translocations, and you can have additions, and then you can have genes that are deleted. So in myeloma, there's usually 3 types of abnormalities. One is called hyperdiploidy, which means that you have extra chromosomes or extra parts of chromosomes, and that's very common in myeloma. Then you have hypodiploidy, which means that you are missing some chromosomes. So when the myeloma cells or the plasma cells are dividing and they have to basically redo their genetic material every time they create a new cell, they can have create abnormalities in there. So the genetic material is not immune to abnormalities. And so these abnormalities usually are those where you can have a missing part of a chromosome, or you can have extra copies, or you can have translocations. And translocations is exactly what you said, when you exchange genetic information between chromosomes. And so the most common ones in smoldering myeloma are also the most common ones in myeloma. So that you have a translocation 11, you have a translocation 11-14, which is very common in myeloma and newly diagnosed myeloma and myeloma in general. It's also very common in smoldering myeloma. You can also see it in MGUS. And it's really one of the most common translocations that we see in myeloma. And it basically what it does is it puts something called the promoter of chromosome 14, which is a gene that has the immunoglobulin that is telling the cell to produce immunoglobulins or proteins. That's what the cells do. They produce antibodies, which are just immunoglobulins. And so they have this promoter very active in the cell because that's their job of the plasma cells to produce antibodies. And so then this gets swapped to chromosome 11, where there's a protein called cyclin D1, which is a protein that tells the cell to divide. And so when you have that, you have cells, the cells that have this translocation express a protein called cyclin D1 and also express something called BCL2. And so that's just a very common and very early abnormality that we see in myeloma. And then you have other abnormalities such as deletion 17p, which is usually a marker that is not a good marker to have in myeloma. However, it depends how many copies of the chromosome are deleted. And that's something that you can do with sequencing, but you cannot see with a test that we do that is called FISH. And we have really few patients with bad abnormalities in smoldering myeloma and MGUS, such as translocation 414, 1416, 1420. Those we don't see very much in smoldering myeloma. The other thing that we see a lot in smoldering myeloma, you can certainly see, especially, in what we call more high-risk smoldering myeloma, is there's mutations, because those are the three abnormalities that we see, and then we see mutations, okay? And so the mutations are in genes called KRAS and RAS. Those are very common in myeloma, and you can see those in smoldering myeloma as well. And so the people have, there's been publications, so Dr. Gabriel has published on these mutations, saying if you have them, your risk of progression may be higher, So all these things seem to correlate a little bit, all the clinical abnormalities. So the higher you have your M-spike, your paraprotein, all these things correlate with us sometimes with, the mutations you have, the genetic abnormalities you have. If you have hypodiploidy, you have translocations and things like that. So those are the common things that we can see in smoldering myeloma.
Okay, great. There's also, I've heard about this mutation. I guess it's labeled the mutation of MYC, M-Y-C, or people call it MYC. And I was reading some information that just said there's a higher incidence of this MYC in smoldering myeloma. What does MYC do, and why do you think there's more of it in smoldering myeloma patients?
So MYC is just a gene, and there are different types of that gene that creates different types of proteins. But what it does is called the oncogene, and it's very common in cancer. It's not just in myeloma. In myeloma, we see it. We don't see it very much. When we see it, it's usually not a good thing. We don't see it a lot in smoldering myeloma. It's mostly people who really have newly diagnosed myeloma or who have relapsed myeloma, and it's really a gene that when you have a high expression of it, it just promotes survival of the cells. And so it can be an abnormality, this is an abnormality usually that you don't want to have. It usually makes cancers aggressive. They're more difficult to treat. So but it's not very common, I would say, in smoldering myeloma. But, if you have smoldering myeloma, and you have, high levels of MYC expression, then that's probably not a good thing. But again, just one thing sometimes doesn't determine the whole story. So I don't want to say because if someone has a MYC, maybe they do really well. So, but that's, overall, that's what happens, and there could be cases where things are not like that. But usually MYC is not a good thing to have in any cancer, an abnormality in this gene.
Okay, great. And you talked earlier about the kind of the microenvironment that some of these you can see genetic changes in the microenvironment. And I think a lot of patients are kind of wondering, especially with immunotherapy playing such a big role in myeloma now, like what role does our immune system play? Because, we hear that, okay, everybody's probably had some kind of initial cancer cell, and most of the time your immune system will go and knock it down, and it doesn't develop into something like myeloma. But how do you test for good versus bad immune system function, and can that predict progression? Is there any tests that patients can go run to say, oh, I have a strong immune system, or I don't have a strong immune system? I know there are a lot of factors, so that's kind of a maybe too broad of a question, but just wanted to get your perspective.
So we can start by saying that myeloma is a cancer of the immune system. So people that have myeloma are very prone to infections, and people that have myeloma usually have something called hypogammaglobulinemia, and that's just a fancy name to say that you don't have, normal levels of antibodies that you're supposed to have, and that's because, again, your plasma cells, they're abnormal. They're not producing the normal antibodies. They're producing some antibody that is non-functional, and that's the paraprotein. That antibody is not helping you fight infections. It's just there, and it can, you have a lot of it. That's when you can get in trouble with the kidneys and things like that. And so patients with multiple myeloma usually do not have a normal immune system. That doesn't mean that they're gonna, not everybody that has myeloma gets into very severe infections, but it is something that is common. And so when you have MGAS and smoldering myeloma, you have usually some abnormalities of your immune system, and that's the most common one. It's very easy to see because it's just a blood work, and everybody can check immunoglobulins. It's very easy to do. And so if you have lower levels of immunoglobulins, that means, that's not normal. Usually you have to have very, very, very low levels for you to run into trouble, to run into infections. So most patients, for example, with a smoldering myeloma, they will have lower levels of immunoglobulins. That doesn't mean that they're going to get tons of infections. It just means it's a little bit lower. So if the levels are very severely low, that's when you can get into more trouble. But if they're not, if they're just a little bit lower than normal, then that's usually okay. So, but most, out of patients with smoldering myeloma have low immunoglobulins, and that's, in different studies that has shown that that's something that signals that you could progress to myeloma if, you have lower immunoglobulins. So that's the number one thing that is very important to discuss. And the other thing is, if you look, you can do fancy tests. So you can look at something called flow cytometry, where you can look at this usually in the bone marrow. Usually you see changes in the bone marrow, you look at the bone marrow, and you look at the cells that are in the bone marrow, and you can see that they express certain markers in the cell surface that make the immune system to be like a little bit toned down so it doesn't attack the myeloma. And you see that the myeloma cells have markers in the surface that send signals, saying, oh, I'm really good, you cannot kill me, things like that. So you see those abnormalities. And so that's why immunotherapy has been so important in myeloma and in other cancers, because in certain cancers we have been able to overcome these limitations of the immune system. In myeloma, we're still trying to figure out how to do that. However, we can definitely use, as the CAR T-cell therapies and everything. So we can definitely use the immune system to attack and kill the myeloma, and we do with several antibodies that we have. In smoldering myeloma, there is really not a way that you can do a test in the clinic and say, okay, these are your results, this is your immune system, these are your, the markers on your cells and all that. But this is, again, an area of research where we can do, flow cytometry, or you can also do sequencing. You can sequence the cells, and then you will be able to tell what is the, how high or low the expression is of certain markers. And some of these markers are the markers that say attack or don't attack, the myeloma cell. And you can see how high they are. And if you see that there is a marker that is very high, that is saying don't, that is a marker that is suppressing the immune system, and you can overcome that marker by making a therapy, then those are the things that you would look for. to do treatments, in the future. But there's not a test, apart from the immunoglobulins. I mean, there's not really a lot of other tests that you can do. You can look in the blood at the number. You can look at the numbers of T cells, B cells. Like, you can look at the different subgroup populations of cells of the immune system in the blood also. But most of the things to do, like immune profiling, this would be like more research, not something that you would you would get a result from your doctor.
Yeah, just like a normal lab you would run. Well, let's talk about treatment, because I know patients with smoldering myeloma sometimes have a really tough time emotionally, because they're like, well, do I get treated? Do I wait? When do I get treated? Is it now? Is it now? So in clinical trials, it seems like there are two different types of treatment strategies. There's this, let's try to cure it by treating it like active myeloma, and just seeing if we can get longer responses or even cure you. Or let's delay progression and use something that's maybe not as, doesn't have as many side effects, or is more like an immunotherapy or something like that. Maybe you just want to kind of first review the difference in the strategies about treating smoldering myeloma, and then we'll talk about the individual clinical trials.
So I think that this is a very interesting question. So there are different types of strategies. I think that we have made a very big step in the myeloma field in the last 10 years. And that big step is that I think most people believe that we have to treat myeloma earlier than what we have been treating it. And that's a huge step, because as you know, it's hard to change things in medicine, right? Once you're used to doing something, it's hard to change. But this is a huge step. So this is I think it's a very good step in the right direction. We have to treat it earlier. And really the question now is not whether we have to treat it earlier, which I think most people you would talk to that are in the field would say, yes, we have to treat it earlier. The question is, what are we going to treat it with? That's the real question now. And so what are we going to treat it with? Well, there are so many different, we have so many different drugs for myeloma that we treat myeloma with. So which ones would be the best to treat patients earlier? And so people are trying out different strategies. And then once, what we're doing is get all the data from all the studies and decide which one seems to be the best. And that can be done. However, studies in smoldering myeloma sometimes take a long time. You have to realize also for accrual, smoldering myeloma is only a subset of all the myeloma patients. So when you do a study for smoldering myeloma, accrual can be challenging sometimes because you don't have as many patients with smoldering myeloma. You may not have as many as with newly diagnosed myeloma. And so that could be something that, can take a long time to have studies done and read. So that being said, yes, there are people that are doing studies where they're giving basically the best treatment that you have, that you would give to a newly diagnosed patient. You apply that to smoldering myeloma. So you do the same treatment that you have for the newly diagnosed patient, but now you give it to the smoldering myeloma patient and you see what happened, right? And when people have done that, what we see is that, the patients with smoldering myeloma have less tumor burden, so it's easier to get them to a remission, because generally it is easier to get, from 2 to 0 than it is to get from 4 to 0. So if you have a paraprotein of 2, it's usually easier to get it to 0, and if it's 4, it's harder to get to 0. And so smoldering myeloma patients have less tumor burden. And so that's one of the observations that we see when you apply this treatment. Usually these are, combinations of 3 or 4 drugs with or without a transplant, and you do that in smoldering myeloma. And what we're seeing is that these patients, it's easier to get to complete remission, and it's also easier to maintain the complete remission, okay? So these are good things. What we're seeing are good things. However, we realize that these patients, as I mentioned before, these patients usually don't have any symptoms, meaning, they could have the anxiety of what to do and all this. But they are not they're not sick like they have these infusions or, they have severe infections that they could die from the infection, or they have kidney problems. It's not like that, okay? It's another set of problems. But it's not the problems of newly diagnosed myeloma patients. And so some people look at this and believe that, giving so much treatment to these patients that, are earlier on, maybe there could be, a different approach that is more suited to these patients, okay? And so also we have a lot of new treatments, a lot of new immunotherapy treatment. We have a lot of new antibodies. We have, for example, something called the BiTE. These are new medicines in myeloma. We have a lot of different things. And so, one strategy is to treat with immunotherapies, to treat with antibodies. So these are treatments that maybe, patients are not all the patients are going to get to a complete remission, but they have very few side effects of treatments, The patients do really well. There's very, they don't usually get hospitalized because of side effects and things like that. So they can have maybe a little bit better quality of life. They don't have to come into the center all the time. So these are the advantages of each treatment. And, the jury is still out on what to do. But, for example, giving high-dose chemotherapy to smoldering patients, high-dose chemotherapy has a lot of risks. The smoldering patients are usually younger than patients that have newly diagnosed myeloma, and so they're going to live with this for a longer time. And so when you do transplant, you're giving really high-dose alkylating chemotherapy, which basically can, create a little bit of a dysfunction in the bone marrow. And so if you're going to live another 20, 30 years, having had this really high-dose chemotherapy, then, that could create problems in the future with, precursors of leukemia and things like that. And so, in my view, that's probably not something that I would like to do, to give high-dose chemotherapy to smoldering patients. But there are other medicines that you can give that are not so harsh, for example, for smoldering myeloma. And so that's where the field is right now, and this is okay. And, we will figure it out. We just need to see the studies and see the data. Right now, in terms of treatment, there are 2 studies that are comparing, the antibodies, the CD30 antibodies, daratumumab and isatuximab, with lenalidomide and dexamethasone. Compared to lenalidomide and dexamethasone, these are combinations that are usually better tolerated than, 3-4 drugs, transplant, and so on. And so this could be the first treatment that we have for smoldering myeloma, but we will compare other newer treatments, to in the future. And so that's where we are right now in terms of treatment. Nothing is approved yet, but there could be an approval coming up in the future, especially with the CD30 antibodies.
Yeah, so interesting. So I know people are looking at using those anti-CD38 antibodies in regular myeloma as well. So they're bringing them up to the front line, and that's what sounds like those studies are doing even earlier in the smoldering myeloma setting. I also know that at MD Anderson you have a smoldering myeloma vaccine trial. Can you talk a little bit about that trial and how it works and just the rationale for that study also?
So this vaccine study, this is a study that is funded through a grant through a foundation. So we would like to thank the Dr. Miriam and Sheldon Adelson Foundation. And this is a study that we're trying it out in 30 patients. We've already accrued about 20-something patients. So we're almost to the point where we've accrued all the patients. And what we do is we do a bone marrow biopsy, and we take the myeloma cells from the bone marrow, and then we do DNA and RNA sequencing of those cells. And we do also single cell sequencing for research, just to know, what changes in the cells before and after the vaccine. So we mostly do this bulk RNA and DNA sequencing where we're looking at mutations. And we look at what mutations the myeloma cells have, and then we look in the normal DNA of the person, the DNA that you pass to your children, and we make sure that those mutations are only in the myeloma cells. Because, we all have mutations that are just normal mutations, okay, like variations in the DNA. So we just want to make sure they're not like these normal variations in the DNA. So we make sure these are really something that is very specific to the cancer. And then we look to see in the gene expression, okay, there's a mutation in this gene, is the gene expressed or not expressed? So the ones that are expressed, we take those, and then you can actually make from the DNA and RNA, you can know what type of peptide, which is just very short protein that you can have that is expressed in that cancer. And so you can make those peptides and you can put them in a vaccine. And so for each patient, we're doing 10 peptides. We put 10 of them. And it depends on where the mutations are and things like that. So each patient gets his own vaccine. And we give 8 vaccines over a period of 6 months, where the first 4 vaccines are given every 2 weeks, and then there's 4 vaccines given once a month. And for the first 10 patients, we just gave the vaccine. And I think the goal of the study was to see whether this could even be done, because we didn't know, first of all, if you're going to have enough material, because some of these patients with smoldering myeloma, they have lower risk of smoldering myeloma. So the bone marrow doesn't have a lot of myeloma cells. So we didn't even know if we were going to be able to even collect the cells and take the genetic material, but we were able to do that. So that's, we're able to do that. And then we know that we can make the vaccine. So on the second stage of the study, we added lenalidomide, because lenalidomide is a medicine that, there's a lot of track record for use in smoldering myeloma. We have large studies showing that it actually can delay the onset of multiple myeloma, and we're only giving it for 6 months, so it's not very long-term treatment. So the idea to give lenalidomide is to stimulate the immune system to recognize the materials in the vaccine and create an immune response. And so that's where we are right now, and that's really what we're doing in this study.
Okay, I think that's just fascinating. Good for you for putting that together. That's just so amazing that you could potentially use a vaccine to prevent progression. You
would be amazing.
Oh, yeah. No, go ahead.
Right? Yeah. Yeah.
I just think it's so exciting that you're looking at approaches like that, because wouldn't that be unbelievable if that works? So very exciting. You mentioned lenalidomide because it kind of boosts the immune system, and a lot of these combinations, like there are trials in smoldering myeloma that have like elotuzumab and lenalidomide and dex, and then like you said, isatuximab, lendex, and daratumumab, lendex. So is it just the factor that it boosts the immune system is why it's always included? And then my follow-up question would be, these cell mods that are coming out, that like iberdomide and things like that, those are also in smoldering myeloma clinical trials. Will those eventually replace Revlimid? Do they do the same thing as Revlimid?
So, they're not exactly like Revlimid or lenalidomide, but, they could, and it all depends on what studies you do. So if you do a study in smoldering myeloma where, let's say iberdomide alone is better than the CD30 antibody with lenalidomide, then why not, Or if you do a study where you do iberdomide with the antibody compared to the antibody with lenalidomide, and it's better. So it all depends on the studies that you do. If you can prove that it is a better drug, that it works better, that has maybe less side effects, sure. And a lot of these things, it depends on the drug development, on what studies we do with the medications. And so it is a possibility. It certainly is a medication that has been very successful in clinical trials for late relapse in myeloma. And, it has mostly, can decrease the blood count a little bit, but it usually seems to be well tolerated. So I think that when we talk about smoldering myeloma, in my opinion, we usually try to do medications that we think are going to be overall well tolerated, and we try to minimize toxicity. So we always try to do that. Mm-hmm. And that's why, the CD30 antibodies are, have been chosen, and they're, that type of treatment is moving forward because, those antibodies are usually very well tolerated in myeloma patients. So that's why that's moving to smoldering. And we're also doing a study with, for example, belantamab mafodotin, which is an antibody drug conjugate as a single agent without steroids, in smoldering myeloma, and the study is going to start in the next 2 months at MD Anderson. And it's a medication that is overall very well tolerated, and it is conjugated to something called MAF, which is a microtubule stabilizer. So it basically goes on the cell, and it can kill the myeloma cell on one side on its own, the medicine, but it can also attach to the myeloma cell, and your own immune system can kill the myeloma cell. So it has those two modes of action, or 2 or 3 different modes of action. And so with smoldering patients, the immune system is not as compromised as in newly diagnosed patients or relapsed patients. And this is a medicine that is approved for relapsed myeloma. And in the patients that it works really, really well. So there are patients with relapsed myeloma who've had, 10 different lines of therapy, have had myeloma for 10 years. You put them on this drug, and they can have a response on, this drug alone without any combination. And so it's a medication that, has a good level of efficacy. And the only problem with this medication is that it can give blurry vision. The MAF is this part that is toxic to the myeloma cell, or MMF. This part can deposit in the cornea, and it can give blurry vision, for example. The difference in our study is that we're going to be giving it's a phase 1 study. So it's basically we're going to be trying to see what is the dose that we can give in smoldering patients. So this is what you were saying about, is the smoldering its own thing, or is it, different? I mean, in a way, it's its own thing. Because, for example, within the study, we already know what dose we can give in myeloma, patients, not just somebody with a different cancer. And we're still doing a phase 1 study, which means we're going to be looking at what is the dose for smoldering myeloma, not just for myeloma, for smoldering myeloma. And we're giving, 15 to 25% of the dose that is given to relapsed patients. So we're going to be giving a lot less dose overall. Yeah. So we're giving a lot less dose overall, and we're also doing a lot of studies to see how the drug is metabolized, so how, smoldering patients metabolize. So this is a study that is really focused on smoldering myeloma, and it is designed to minimize the toxicity that the drug has, which can give blurry vision, which is reversible, can also give dry eyes, but these are reversible. And there's no blindness or anything like that. I've heard some people say that, but it's not true. So, and it's also, and it's also given, we give it like one infusion, 30-minute infusion every 2 months. So it's,
every 2 months, wow.
Yeah, someone who is smoldering myeloma who is working, who doesn't, you don't necessarily want to give steroids to these patients. You don't want to give a lot of fatigue. So this medicine doesn't give a lot of fatigue, doesn't give, the main 2 things are you can have the blurry vision and you can have like a little bit of decreased platelets. But patients with smoldering myeloma usually have really good numbers of platelets. So, we're not expecting it to be a big thing. And you can really modulate the toxicity of the drug in the eyes with the dosing and the schedule. So we have really modified the dosing and the schedule to see if we will have efficacy with a decrease of the dose. And this could be something that, if it has a lot of efficacy, could be very important. And so I just wanted to mention it here as well.
Oh, that's so important. So that patients might know that drug by the name of Blenrep, and our last radio program was actually on keratopathy. So if you have patients who are interested in that, I just barely posted that on the website, and you can kind of go read about that. But like what you're saying in terms of dosing and frequency is really important, because when the doses were reduced, there was less of that, and that was given like every 3 weeks, and you're giving it every 2 months. So I'm so excited to see what you're going to learn about that.
That's right. The study has been made to see if we can have a lot of efficacy while really reducing the dosing and the schedule. And really, when you calculate the doses that you give, it's really the lowest dose is 15%, and the highest dose that we give on the study is 25% of what was given on those relapse studies that you mentioned on your prior podcast.
Oh, wow. And a lot of the patients didn't even, some of the patients didn't really notice much about their eye side effects. So that will be really interesting to see
That's
what
correct.
happens.
A lot of patients
And even when, that's
so we'll
totally
see what
fascinating.
happens. We'll see. Yeah.
Yes, well, we're excited to see what you learn. Okay, I have another question. Oh, I just realized we're running out of time. I have so many more questions for you. But if more patients with smoldering myeloma have the 1114 translocation, and that drug venetoclax is good for patients with that, I know it's not approved yet in myeloma, and it's in a lot of different clinical trials. But is that something that should be considered in smoldering myeloma if somebody has that genetic mutation?
Yes, I think so. I think that, if we can do a study and prove that it is safe in smoldering myeloma patients, that it doesn't have side effects that we were not expecting, I think that we could see really good responses just with venetoclax. And that drug, it could be given also without steroids, just a drug, and it's usually just a few tablets a day that you take every day. But I do think we would have to have, potentially a study would be better just to know if there's anything else that we have not picked up, because smoldering myeloma can be a little bit of its own beast. So, but yeah, I think it should work well in smoldering myeloma patients that have a translocation.
Do you know of any clinical trials that are planned for that or no?
I don't know of any trials, but I haven't heard of any trials. But certainly something that could be worth doing, and I know that there are other physicians that think the same.
Okay.
I think that, because there was a little bit of trouble. Remember venetoclax, they did the Bellini study, and there were a lot of infections in that study, and so the FDA had to go, and so there was a little bit of ruckus with all that. It's still, we give venetoclax a lot in myeloma with translocation 1114, and we usually have very good responses, and it works really well, and I'm very happy with it. But when there was a big clinical trial and newly diagnosed and in relapse patients with this drug, all comers, not just the ones with the translocation 1114, they ran into some safety issues. And so, maybe that was something that precluded doing other things, maybe in smoldering myeloma. I don't know the whole story, but it could be.
Yeah, so interesting. Okay, well, we only have just a few minutes left, and I have several other questions. But if anyone has a question for Dr. Manasanch, you can call 347-637-2631 and press 1 on your keypad. And then your question, I'll be able to see if you have a question or not. In the meantime, while we're waiting, can I ask some basic questions about just smoldering myeloma, just tracking and maintenance and things like that? So, one more question about the treatment strategies. So if you treat early in the smoldering myeloma stage, will that affect the overall survival once you progress to myeloma? I think I saw a study that the answer was no, but just wanted to confirm that with you.
So this was something that people were worried about when we started to do studies in smoldering myeloma, and the answer, based on the data that we have, is no. That in fact it seems that if you're treated earlier, in fact you live longer. That's what it seems to be. That's what it seems to be right now. But of course, with science, maybe there could be a study tomorrow contradicting this. But as it stands today, it seems that if you treat earlier with medicines that have very high efficacy and you get rid of the myeloma, that seems to be the best. To do it earlier rather than later.
Yeah. Okay, perfect. And then on assessment, in how often should a smoldering myeloma patient be assessed, and then what's the role of imaging in that assessment as you have myeloma? I know that's one of the most common questions that patients have.
So usually patients should do with smoldering myeloma blood work or urine every 3 to 6 months. If you've been on follow-up for 10 years and nothing has changed, you could probably do once a year. It depends how long you've been on follow-up. But usually it's every 3 to 6 months. You have some monitoring, blood work done. You can do 24-hour urine. And then with the imaging, it depends. You could do every year or every couple of years, depending on your risk. And, of course, if you have pain or something, you should have some imaging done of that area as well.
Okay, great. Well, you've given us some new things to think about. I had no idea about the BlendRep study and your vaccine study. So I'm just delighted to hear about that. And just to mention, too, before we end, and I know we're out of time, you mentioned Dr. Gobriel's study. It's for smoldering myeloma patients. There is a study that you can join as an MGUS or smoldering myeloma patient. It's called the PCrowd study, and you can go to enroll.pcrowd.org, and that's a study, that's just an observational study, so you don't even have to go anywhere or do anything, but you can send in samples. But our show today, Dr. Manasanch, just reminds me of the importance of seeing a myeloma specialist like you and going to centers like MD Anderson, because you have so many studies open and available. And if I were a smoldering myeloma patient, I would be looking for a clinical trial to join, because to me, I think I've heard the experts say you should only get treated inside of the context of a clinical trial. But this just reminds me that it's amazing that you have these studies running, and that your research is just so dedicated to learning more about this subset.
So, yeah, I agree. I think that especially for smoldering myeloma, you definitely want to go to a center of reference where there's somebody who has some experience, because I think that, if you don't do a lot of multiple myeloma, you may miss things, or, you really want to go to somewhere who really knows the disease. And we know that could improve outcomes as well. And now with the trials, there are so many trials in smoldering myeloma. Again, you can choose to do vaccine. You can do different types of antibodies. So there's like a lot of, we have a lot of options for patients right now.
Yeah. So I would just encourage patients to meet with a myeloma specialist like yourself and look for centers that do have a lot of clinical trials open for smoldering myeloma, because that may be your very best strategy. So just a reminder that I just think clinical trials are the way that we do this research and figure these things out that are so important for not only ourselves, the people that are joining them, but for everybody that comes after us.
I agree. It's extremely important, and thank you so much for the invitation to be here today. This has been a lovely discussion.
Oh, I had so many more things to ask you, but we'll have to end. I just thank you so much for joining us today. Thank you for sharing your expertise. Thank you for caring for myeloma patients every day. I'm just so impressed all the time at the dedication that you have to your work, and as a patient, I'm just so very grateful.
Thank you so much, Denny.
Yeah, thank you for joining us today, and thank you for listening to Myeloma Crowd Radio. We invite you to join us next time to learn more about what's happening in myeloma research and what it means for you.
Hello, it is Ryan, and we could all use an extra bright spot in our day, couldn't we? Just to make up for things like sitting in traffic, doing the dishes, counting your steps, all the mundane stuff. That is why I'm such a big fan of Chumba Casino. Chumba Casino has all your favorite social casino-style games that you can play for free anytime, anywhere with daily bonuses. That should brighten your day a little. Actually, a lot. So sign up now at ChumbaCasino.com. That's ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.